Afternoon, everybody. Welcome to today's second session of the Healthcare World Festival for this November. We have a slightly tongue-in-cheek question today: how to digitise your health system. It's about as broad a topic as you could get, and really, it's the big question for me as we look at where we are coming out of the end of, or nearly at the end, hopefully, of the coronavirus pandemic. We have the unintended consequences of what we've been through in the last 18 months, in that what we've done is probably advanced the cause of digital healthcare by, some would say, 10 years. It's an interesting question, just how much so. Certainly, the global population, the UK population particularly, are far more accepting of the idea that healthcare will be delivered via their mobile phone screen in their living room, rather than having to go to a hospital or a clinic. We may well look back in 10 or 15 years and think that the idea of taking people that are sick and sending them to a building full of sick people never made any sense in the first place. But where are we now in terms of the development of digital healthcare? And most pertinently, if we were to put together all of those digital technologies and all of those innovations that we've seen arriving on the scene over the last few years, and almost one a day in the last couple of years, do we have all of the technologies, all of the innovations, all of the jigsaw pieces, if you like, to create a fully digitally integrated health system? Joining me to debate this topic today, we have a wonderful panel. We have, in no particular order, Nick Fox, Chief Commercial Officer at NHS Digital here in the UK. We have Dr. Nitty Paul, who is the Global Medical Director at KPMG, and also the Director of Harbour, who are an investment advisory firm for digital healthcare. We have Russell May, who is the Field Director for Dell Technologies for the Middle East. Abby Shecker, who is the Head of Digital for Mott MacDonald. Simon Swift, Managing Director at Methods Analytics. The brilliant Dr. Anushka Pachava, who is both the Deputy Medical Director at Vitality and a spokesperson on AI for the United Nations, no less. Dan Morris from Brethren Britain, and Elliot Engers, who is the Chief Executive and Founder of Infinity Healthcare. So thanks to all of you for joining us today. What I'd like to start with, we talk about this idea of a digitally enabled health system and what a digitally enabled health system actually looks like. To start with, I'd like to give Nick Fox the opportunity from an NHS Digital perspective to give us the UK view. What is the UK doing, Nick, to try and create and enable a digitally enabled healthcare system? Over to you.
Thanks, Steve, and afternoon, everyone. Lovely to be here. So Steve said, I'm Nick Fox, I'm Chief Commercial Officer at NHS Digital, and for those of you who don't know us, we're the National Data and Technology Delivery Partner for the NHS here in England. So I guess starting point is, when digitising a healthcare system, you obviously need to start with considering a number of factors. What's the starting point, the maturity of the system that you work in, what's the scale, what's the structure, what's the governance and funding mechanisms of that healthcare system. And needing to balance around what elements should be done once and done centrally, what should be done locally, and how those local and national interactions work together. But I think most importantly, you also need to start by asking the question, what do we mean by digitisation? I think it means lots of different things to different people. Is it around the core clinical systems? Is it around citizen-facing applications? Is it about the data that underpins, all of this? But I think, when you talk around digitisation of healthcare systems, I think that, the consistent theme and aim that actually hasn't changed probably in 20 years or more is that of integration. So integration of healthcare systems and integration of the technology and the digital systems and data that, that underpin ultimately healthcare delivery. And the more seamless that these integrations are, the more seamless care is for citizens and for patients. But of course, we also don't live or work in a static environment, do we? So, Steve mentioned some of the changes through the pandemic. The delivery of healthcare and the modes of healthcare are changing, and then the technology environment's rapidly changing around us as well. So, it's a continually moving challenge that we're all striving for. So, here in the NHS, Steve talked about the sort of the parts of the jigsaw. My personal perspective is we have many parts of the jigsaw, but we've got some missing pieces, and some of the pieces don't really fit together that smoothly. And I'm just going to spend just a couple of minutes maybe just talking about some of the different components of our healthcare system and just reflecting on those a bit. So I'm just going to briefly talk about general practice and primary care, secondary care and the hospital sector, and then sort of the national systems and capabilities and some of the glue that helps to hold that together. So in general practice, I think relatively we've got a reasonably mature landscape of clinical systems provision that's grown up and iterated over a number of years. And at a national level, we centrally hold the contracts that help manage that market and help set the standards and capabilities and how they mature, over years. In the hospital and secondary care sector, digitisation is very much owned by the individual hospitals, many of which are very large and complex organisations. And I think we see a wide range of digital maturity, from some very mature organisations at sort of HIMSS level 6 and 7, to the less mature organisations that have got aspirations but have not got the capability or the capacity to mature. And the strategy over the last few years has actually just been more of one around targeted funding, either at those that are more mature or those that are less mature. And then we have a number of elements where it makes sense to do once nationally, and here at NHS Digital we deliver many of these systems and services for the NHS. There's a long list, but just to give you a few examples, we have a single demographic system for all patients, we have a single identity management system for both clinicians and also now citizens. We have standardised booking and referral systems between primary and secondary care. A single NHS app where you can view your medical record and you can interact with general practice, and a single NHS website and consistent triage algorithms for urgent care when you either pick up the phone or go on an online service through 111 to be followed through and routed through various algorithms. And I think the importance and some of the criticality of some of those national systems and services really came to light through the pandemic response, where we were able to, in one hit, effectively respond to the pandemic in different ways. So in the early days, it was like, what is COVID, what is coronavirus, getting the clinical advice, getting the triage out, through single algorithms. As we went through the pandemic, we were able to stand up in really, really quick time the digital systems and services that sat around the vaccinations programme. And in many respects, that was reusing and connecting to a lot of those national components that were already existing and modifying and adapting for a new use. And then, likewise, with the COVID pass to allow international travel, we were able to surface that through an existing NHS application. So that those national elements complement a lot of the local and locally owned clinical systems, but do provide a lot of the glue in the interactions and do allow nations to respond consistently and often quickly in particular circumstances. So finally, just to summarise, I think probably three things when you're thinking about this question. So first of all, be clear about the scope. What do you mean by digitisation? Secondly, it does make sense to do things centrally, but you need to carefully think about what those things are and the balance of central and local. And then thirdly, and this is probably the most critical point that people always talk about, but the job will be much easier if you have clear technology and data standards and a clear enterprise architect that you work within. And I think that is the challenge that we consistently face. But if you have that, and you're able to incentivize the system in which you work to work to those standards, then you will be in a much better place at the start and throughout your journey. And then my final point is, although we are part of the NHS, we're a public body, I don't think there's anything that we do on our own. We do it in partnership with industry, and we work with some fantastic organisations on the digital and data delivery side, both here in the UK and internationally. So, it really is a partnership approach. When you think about the skills needed to digitise healthcare systems, we need to think about how public and private bodies and partnerships can work together. So thanks, Steve. Back to you.
Thanks, Nick. That's a really great, I think, summary of both where we are in the UK right now and kind of how we want to get where we want to go. And what I'd like to do to kind of kick us off here is take that question around the panel in terms of the key question I think that you posed there, which is the one about what we've got to decide first. What is digitisation? What do we mean when we talk about the creation of an integrated digital health system? And I think where I'd like to start here is by looking at a couple of our panelists who are more familiar with outside of the UK. So Russell, let me come to you first, sitting as you do in the Middle East. How does what Nick has described in terms of the UK system compare with what you see in Middle Eastern health economies? And from your point of view, a Dell perspective, what does a digitised health system look like?
Yeah, thank you very much, Steve, and thank you very much, Nick. That was a great summary of NHS Digital as well. I'll just quickly introduce myself. I'm Russell Main. I'm the Healthcare Field Director for MERAT, that's Middle East, Russia, Africa, and Turkey. And my role is really to support healthcare organizations in their digital transformation and connect healthcare organizations to our healthcare, Dell Healthcare and Sciences, Life Sciences team to be able to improve patient care. So the question really about what is fundamental, what are the key components to a digital health system? I think that the core foundational component has got to be security. You'll know that over the last year through the pandemic, there's been a 45% increase in cyber attacks on healthcare organizations. So any piece of work that gets done to integrate different technologies needs to have this security mindset front and center. There need to be checks and balances, there need to be controls, and access management needs to be really clearly defined. Because without that, you stand a great risk of not only damaging reputation and damaging the organization, but damaging patients as well. So clearly the first thing is to be resistant to attack and to be able to be resilient in the face of attack. And then secondly, the important thing I feel is around having a look at the patient and the end user experience. It needs to be seamless through the points of care, through the venues of care. And I believe that these are the fundamental building blocks to a digitized healthcare system. I just want to quickly add about the Middle East as well. The Middle East is in a really strong position because in many respects, we're quite digitally mature when it comes to healthcare. But that comes with its own problems as well, because what we have is very digitally mature systems, but we often struggle with the fact that there are too many moving parts and it's very difficult to interface all those pieces together. So a lot of the work that we're doing at the moment is really about leveraging the current technologies as opposed to adding new technologies on.
Interesting point to make. I want to bring Nitty in at this point because Nitty, you've got experience working in, God, I don't know how many different health systems. What's your perspective in terms of where we are at the moment and where we want to be in terms of what that future digitally enabled health system looks like?
So hi, thanks, Steve. And I'm delighted to be here today. I've just got off a plane from India, actually.
Somebody
well, I'm a bit knackered. So if I say something wrong, Steve, just catch it for me, please. So just on that, I've come from a system that's buzzing with innovation, buzzing with ideas, fairly fragmented healthcare system where 60% of costs are still out of pocket for consumers. So I just want to take, and Nick, I've worked in the UK NHS for, seems like 100 years, but I left about 13 years ago to pursue my own journey across the world. And my passion is affordable healthcare and access to healthcare. So some of the countries that I go to in India, Pakistan, Bangladesh, Indonesia, Thailand, Egypt recently, Mexico, Brazil, we don't have systems like the UK. They are not very mature. I also work, Russell, in Saudi. I'm helping the payer system there. But what I find is that we forget sometimes to take a consumer-centered digital approach. So in systems that are mature, it's very much around the system becoming digital. So I just want to take a slightly different view of this, Steve, as you would expect me to, is really take that consumer-centered approach. Where you take a consumer-centered approach to this and you say it's whose records are they? They're the consumer's records. It's the patient's records. They're not ours. When you start looking at what the consumer journeys are looking like, how do you interface them with payer systems? So, we don't have a single payer in India. There's not a single payer in Indonesia or Vietnam. Same applies in Egypt. And some of the stuff that we've done there, questions start to rise. If an insurer is paying for you or someone else is paying for you, then questions rise about whose data is it? So from my perspective, the data is the consumers. How you choose to interact with your own data is your problem, as long as you've given informed choices. So on the one hand, I think the consumer side of this is really buzzing in countries that I've just described. And people are starting, and I think, Dr. Anushka, I've heard you speak before. I think you perhaps from a vitality perspective can shed some light on that as well. And then on the other side, you have a question of digital literacy in those economies. And digital literacy is not about being able to read and write, which is where people get very confused. And I have this said to me in the UK NHS many times, well, your patients can't read and write, how on earth can you offer, this was years ago, by the way, Nick, where you can't offer them structured diabetes education programs run by patients themselves, and it's completely proven wrong. Those were the best ones that were run. So this is digital literacy in a different kind of way, and allowing access. But the smartphone revolution, in India, I bought a smartphone for 28 quid. Now, the smartphone revolution has really, really accelerated some of this. And, AVRs, videos, hi, hellos, TikTok. We just launched with AXA, just launched something in China. And in Indonesia, we had 8 million views in a day on TikTok. Now, the platforms, the social media platforms as well, that consumers are starting to use are very different. So that's the second bit of it. And then the third bit is how do you integrate, and where the twain shall meet is also interesting. I see, as with my Harbour hat on, I see tons and tons I see probably 50 to 100 startups a month. We screen them for the investors. And we find that actually health ecosystems are not building. You've got individual apps for one disease. You've got consumers, the minute they have to download an app, your drop-off rate is 70%. So people don't download this and keep that on forever. So and people won't have bandwidth. They won't have enough data storage space to constantly download apps. So what we're also finding is that third bit of creating health ecosystem around the consumer, you need to think differently as well. And mature and not mature have to think like that. We find that meeting people on the platforms they're already on, Line in Thailand, WhatsApp in other countries, is where you meet. Facebook Messenger is where we are meeting consumers. And when they're already using that, a lot of disease management programs, which are using already functional stuff that people are already using, you find there's much better usage, the drop-off rate is lower, you're getting better health outcomes. So those are the three things that from a consumer perspective, I've learned, having worked in kind of 8, 9, 10 countries, having launched both telehealth bundled with low-cost insurance, also bundled with chronic disease management, that the health ecosystem has got to come together. And in India, we've seen a roll-up happen. I don't know whether you guys heard about 1mg and ThyroCare rolling up. 1mg is the largest pharmacy platform in India, distribution platform, and they rolled up with the largest private labs, ThyroCare. They've got the biggest number of healthcare consumer now. And so what we see is a new health ecosystem developing and a new provider of healthcare, the different kind of click and brick that I've seen emerge. So I'll stop there, Steve, for others to pick it up.
No, that was fantastic, Nitty. Thank you so much for that. I mean, a couple of key things that I took from that in particular. I love this concept that you're developing an ecosystem. The problem being that if we ask people to develop and we ask people to download lots of different apps for different elements of their healthcare, how many of us, periodically, I do this, I'm sure you do, periodically you'll look through your phone and you'll go, well, I don't use that one, I don't use that one, I don't use that one. And the problem is that when you've got 6 or 7 different healthcare apps on there that you only use very occasionally, you're going to get rid of most of them, which means you're kind of missing half your audience. Interesting one actually to take back to Nick later on in the conversation in terms of the way that works with the NHS ecosystem and people using the NHS app. But the other point that you raise, and I want to as you suggested, fire this one on to Anushka, is that question of, okay, in the UK, we have a single payer system. That's one thing that kind of makes sense and is sensible. But when you're in jurisdictions like Russell is in the Middle East or in the US or wherever else, when you have multiple payer systems, how do those ecosystems develop amongst different payers? Before I come to you with that, Anushka, a couple of quick things. Firstly, welcome to Danny Seiden from Nextgate, who I think had problems.
So sorry about that, Steve. Yep.
No worries,
sorry.
Nick. So Dan, so another august member to our panel. And secondly, to our audience, I can see that there are lots of you watching the session. Please don't be shy. There is an email address on your screen. It is info@healthcareworldfestival.com. If you have questions for our panelists, that email is coming straight to me, and I will be very, very happy to post those questions on your behalf. But Anushka, over to you. The multiple payer question, how does that influence the creation of digital ecosystems?
Thanks, Stephen. Thanks, Nikki, for throwing the question my way. Great to see everyone and be here and be present. I think for me, Nitty touched on a few facts that I think we should take a step back and reflect on when we're talking about digitalization. Digitalization means different things to different people. And what we have to recognize as a sector is digitalization in healthcare is never going to be the same level of digitalization in e-commerce or digitalization in financial services. Healthcare has and remains to have to today, and I think it will always be in our lifetime, an emotional aspect attached to it, and a contact aspect attached to it in terms of the relationships you build and how you seek and enjoy and experience care. So for me, I think when we think about digitalization in healthcare, there's two layers, and we see this in the insurance space as well at Vitality. It's, are we digitalizing for our business to achieve business effectiveness, business efficiencies, operational excellence, and such likes? Or are we digitalizing to have member impact, member being our insured members? And if you're digitalizing for the customer, it's very unlikely that what you want to do is exactly as you want to do for your business. There might be some synergies and dependencies, but it's very separate, two separate ecosystems, two separate experiences, and two separate almost architectures, front ends, back ends, and such likes. So I think that's the key question to answer in healthcare. And Nitty touched on it. Who are we digitalizing for? And it might be that we digitalize for both parties, but they're very separate transformations that need to occur and very separate change management. There's very little we have to do really to digitalize for the consumer in terms of change management. Consumers have showed us as a result of COVID, they're willing to get on, get active, start downloading the NHS app and interacting and booking and scheduling services and having video consultations. But of course, there's a huge change management for the physicians, the healthcare practitioners, the hospital systems, and that ecosystem that we need to think about. I'm going to move on. So we've talked about, I guess, what digitalization means and who are we digitalizing for? And the processes differ in both. I think particularly with the insurance space, and Steve, I'm going to correct you because you said the UK is a single payer environment. It absolutely, most definitely isn't. We have a private medical
apologies for that.
We have a private medical insurance sector in the UK. Vitality, AXA, Bupa, others are part of that. And in fact, that sector is growing as a result of the pressures that we're seeing on the NHS. Now, I think in the UK, we're very, very privileged to have an NHS service. But equally, I think whether you have a payer environment or not, the key critical piece is, and Nitty touched on it, is what is the platform that will enable data fluidity? And that's the concept we're trying to achieve through digitalization. There's no point in having loads of apps that all hold different data on you if your healthcare practitioner can't see that data. There's no point in having loads of apps and one tells me I sleep well, mine tells me I sleep terribly, and then the other one tells me I eat terribly, and they haven't joined up together to say I'm just a terrible person living a terribly unhealthy life. And they haven't recommended me something based on the holistic person that I am. So I think that data fluidity aspect is one that we digitalize for, and that's if I'm not mistaken, the intended impact of digitalization. And when we bring in that data fluidity, you're right, it's payers that have a role to play, but it's also equally, I think, patients, physicians, and politicians, I hate to say all the Ps and providers, so let's go all 5 Ps, that have a role to play in what that infrastructure looks like. And before I finish, I want to take us back to something that I guess came out of the gig economy, and that's the Uber platform. Why is Uber so successful? Because it has positive benefits for buy side as well as sell side. The drivers benefit, the consumers benefit, and Uber sits as the infrastructure, the layer in the middle. And what we haven't done in healthcare is work out what that looks like for us. How do we ensure the patients benefits? The patients have autonomy of the data. The patients allow and permit and consent to data fluidity, but also all the providers, whether they're healthcare startups, whether they're insurers, whether they're charitable networks, whether they're social services, whether they're primary, tertiary prevention ecosystems, all connect in and flow through that single layer of architecture. Now, I know some of the disruptors in the world have talked about that layer being blockchain and distributed ledger technology and all sorts, and we won't go down that rabbit hole today, but I think that's the key concept we're trying to achieve here, is that platform ecosystem that benefits what we would say was buy side as well as sell side.
So thanks very much, Anushka. Well, I think we'll finish there because I think Anushka's just completely solved the problem. So that's, it's kind of pointless going on any further than that. Brilliant
contribution. Great, lunch on you, Steve, then, right?
Absolutely. Well, we still haven't sorted that one out, and I think we need to. Question of data fluidity, really interesting. And actually, we talk about the kind of number of apps you have on your phone, and the fact that you need to kind of amalgamate around one or two platforms. But the other question, if you're going to have multiple technologies and multiple technology entry points to a healthcare system, how data flows between them is absolutely the key question. And there's only one man I can ask that question of, and is, of course, Simon Swift from Methods Analytics. So now that Anushka has solved the problem of how we create a digitally integrated health system, Simon, over to you to solve how we create the delayed data fluidity to make it work. And if you don't solve it as well as Anushka solved the first one, then you've failed.
I'm off. I think Nick touched on it, and conceptually it's really quite simple. It's about standards. It's about standards for data, and it's about standards for interoperability. And those are, to some degree, in place already. We have standards for interoperability. We have the old standard, HL7. We have the new standard, FHIR. They work. Standards for data are a bit more messy because something that Nick also touched on around the plurality of providers of hospital systems, of GP systems, means that they each have their own data warehouses with their own taxonomies, their own ontologies, different data sets, and mapping these together is very difficult and very complex. A lot of work we do is mapping data from one system to another and building nasty data migration transfer processes. Standardizing nomenclature, standardizing the names of fields so it's automatic, it's easy to automatically map data from one system to another. Those are the things that in the sort of the deep back end of any digital health system are necessary to enable data fluidity. There's also something Russell touched on, which is potentially a bit of a blocker at the moment, and that's security. People are so panicked about risk, and to some degree I use the word panicked carefully, because I think the reality is, from a technological point of view, security is largely a solved problem, not entirely, but largely, but the public concern about it has not yet caught up with technical reality. But for example, we were looking at something that we'd been asked to build, which required the user on their smartphone being able to bring together data from multiple apps into one place. But the mega platforms, the Apples and Googles, have actually implemented rules to prevent precisely that happening on-device data sharing between apps from a security point of view. And we all know the story about the fact that they actually had to change some of their core platform to enable the NHS proximity piece using Bluetooth. So this is where good intentions, this app can't share data with this app on your phone, actually start to cause problems. And it means things have to happen in the back end. So I think data fluidity is key. If I can just back up all the way to the beginning of this a little bit, because I think data fluidity is necessary to us to get to to the nirvana of everybody having access to the data they need at the time that they need it. But I think the whole digitization, one of those concept, there are two fundamentals which I don't think have been mentioned yet, which I want to sort of raise and then lob back at you, Steve, for you to pick somebody else to pick on. One thing that Anushka got close to in her discussion of it, is it for the business or is it for the consumer? And that is, what is the purpose of digitization? And I think that fundamental needs to be thought about a little bit more often. Why are we doing this? Is it to improve outcomes? Is it to improve access? Is it to improve, the bottom line for a business? Is it to improve efficiency of a healthcare system? Why are we digitizing this particular thing that we're looking at? And until that question is really considered in the context of every choice to do this or that or the other, people will make mistakes, or they will, design some whizzy shiny app and bring it to Nitty at Harbour. And Nitty says, well, what's this for? Why are you doing this? This isn't investable because I can't see why anybody would want it. And, and I and many others have come up with harebrained ideas to build a shiny whizzy thing. But unless you think about the purpose, what it is there for, you're banging your head against a brick wall. The other thing that we haven't touched on yet, which I think underpins all of this, and a lot of the digitization we've seen over the course of the pandemic, is what are we aiming to achieve? A lot of the digitization during the pandemic has been taking something we do now and stuffing it into a digital model, but not changing the model. So, for example, the NHS has been staring at itself for decades and saying, why do we do outpatients? Why do we do 18th century, come and see the big doctor in the big hospital and have a conversation and then leave again? And over the pandemic, an awful lot of that has changed to not being face-to-face. And there's been lots of noise about this in the papers in the UK recently. And I may get in political trouble here, fake news about GPs not doing face-to-face during the pandemic, which is rubbish. They have continually and at very significant volumes, but a lot of that activity has moved to a digital channel. And a lot of patients have loved it. There are some areas where it's looking like quality might be suffering, but that's relatively niche. But we've taken the same model, speak to the big doctor in the big hospital, and we've just put it on a phone, which is a benefit because it means you don't have to travel and you get by and large the same value with the same experience. But we haven't looked at what are we trying to achieve here, because what we're doing is we're still delivering an old-fashioned responsive sickness service. You are sick, we will put you together with somebody who might be able to help you. What we can do with digitization, with data fluidity, with data integration, with system integration, is move to a proactive wellness service. That's what digitization really enables, and it's a complete paradigm change. So I'm going to lob that at all of you and shut up.
I think there's a couple of things that come out of that for me. I think we had Stephen Dorrell, the ex-health secretary, on our session yesterday, and he talked about the difference between health and healthcare, which I think is sometimes gets forgotten about. The idea health is I have good health. Healthcare is the kind of reaction to being ill, and sometimes with the way that our systems have developed, and again, it's kind of building blocks on kind of centuries of doing things in particular ways. And that actually speaks to the second point that you raised, which is that, and you and I have discussed this before, you look at the way that we sit now and you have a linear healthcare system. So what you've got is, I'm ill, I go to a GP, the GP then either provides me with a service, provides me with a treatment, or triages me to move me on to the next stage of healthcare, which again, linear through to acute care, through to hospital, etc., etc. What we probably need to think about now is, how do we kind of, our idea around a digitally enabled healthcare system actually allows us to route people around that system in a completely different way. Why go straight to a GP when you might be able to do some kind of diagnostic from home, some kind of AI-based system, which takes the GP out altogether and moves us on to the next point. I think it's a really interesting question about how you redesign a healthcare system and add the wellness element to it. I think, Elliot, I'd like to come to you next, because as an innovator yourself, as a CEO of a digital healthcare company, how do you see your business fitting into this potential new ecosystem?
Big question. I'd like to
we don't do small questions on this.
No. So I'd like to echo a lot of what's been said before. So like moving to a more consumer-driven approach seems very sensible to me, and a more patient-centric approach. I think what Simon is saying is very aligned with our way of thinking, which is that digitization means that, or digitalisation means that you can move to a more proactive rather than reactive service. But what I think that means for technology is that means at the moment we have systems working in silos. So you have hospital systems, you have primary care systems, you have community systems, and these systems won't talk to each other. They barely talk. The internal systems within the acutes won't talk to each other very well, and they certainly won't talk between the acute and primary. And I think that there's a lot of work that can be done there around standards. I also agree that these standards do exist and they do work. They're always improving. What's not happening is that they're not being enforced or being required. So I think the standard should become that the standards are standard and that they're required. So I think that there's a huge amount of headroom in sharing information between silos. And I don't just mean health records. So I think that that's also a largely solved problem, which is that like databases of clinical records about patients can be shared between primary and acutes. But what's not being done is care's not being coordinated in a way where we're seeing it more holistically. So how can a GP have visibility of what's going on in the community and visibility of what might have happened in a hospital, for instance? I think that will allow us to be much more proactive. I also think that we could start to use the data we've got better. So identifying patients that are rising risk in the community, and then having a neighborhood team that could identify that patient has got 2 comorbidities and they've got a 70% chance of an A&E attendance in the next 6 months. It's going to be better for them, better for the system to get a team out to that patient and proactively care for them. And technology can do that in a way that can't be done at the moment.
Thanks, Elliot. That's a really useful contribution. I want to come back to this question because this is Healthcare World. We're a global event and a global publication. I'm curious to understand how this is working in other systems. So, 2 people with experience in other systems. Abby, I'll come to you shortly. I'm not McDonald. I know you work in a lot of developing countries, so I'd like to get a perspective on where they're up to in some of these areas. But Dan Sidon, you're, is it Sidon or Sidon? Sorry.
Close to Sidon. Yeah, the second.
Sidon, right, okay, that's brilliant. Thanks for that. So Dan, obviously you're sitting there in the USA with what I have to say is a very impressive piano in the background.
That's digital, by the way. Yeah, go ahead.
Of course, I would expect nothing else.
Yeah.
What's your perspective sitting in the US listening to all of this? Where is the USA at the moment in terms of its development towards a digitally enabled health system?
Oh, dear God. Maybe I could move over to the UK. You guys seem to have your act together certainly better than we do here. I would describe it over here as a little bit of a kind of Wild West situation in the sense that, obviously we don't have this integrated model that we see in the UK. And by the way, we are the implementer of the community health identifier in Scotland. So we do understand how your systems work over there. We do have a lot of implementations in England, but in the US, it's really an acute problem where, from our perspective, and just to level set a little bit, our main service and product is really around the identification of patients. And in England and in Scotland, you guys have done a far better job in putting the infrastructure in place to do that kind of identification through things like the patient demographic service and the NHS number, and like I said, in Scotland, the community health identifier. We don't have that in the United States, and every attempt at producing a unique identifier in the United States has pretty much failed, and mainly on the grounds of concerns around security and whether or not a single identifier would enable the various actors to get more information about you than they really should know. Would you be denied care if they had a more complete history? Would a payer not provide care? These kinds of very fundamental questions, which, like I say, unfortunately in the United States, it's really, it's a struggle, let me put it that way, to get anywhere close to what we see in some of the other developed nations. So, I think that on the questions around, data fluidity from our perspective, and maybe I'm biased because that's, what we do as a business at Nextgate, but for us, a big component of data fluidity is the identification of the patient, because, all these other interoperability questions about, nomenclature and how do you represent these various attributes, and a lot of these things that HL7 and FHIR and these other standards have helped with that. At the end of the day, if you have 30 different systems, and some of our customers have hundreds of different systems, then how do you identify the patient uniquely, especially if you don't have something like an NHS number or CHI number? But even if you do, just like others have said, that doesn't necessarily mean that there isn't a private sector, that there aren't other things outside of, hey, you're sick, I need to provide you care. So for example, social services in England was one of the main reasons why we introduced our patient identification capabilities there, because those systems didn't have the NHS number mandated as part of the information that they gather. So, I could go on and on, but I do believe that patient identification is the absolute most important thing. I don't think a modern form of that really is something like a single number, like an NHS number, because there are real questions around consent to the access to information that a single identifier is a bit troublesome. But there are standards around decentralized identity that are very important, and I think that sooner than we think, we're going to see other industries adopting that, and it's going to spill into healthcare, and we're preparing ourselves for that at Nextgate, because we know that the future of identifying individuals is going to fall within that kind of decentralized identity space.
That's really interesting. I'm going to come to Abby for the developing world question in a minute, but I want to divert us via Dan and take aim at the lawyer in the room. Dan, is this all your fault? Are you getting in the way of interoperability? Are you getting in the way of data flow with all of your laws and rules and regulations?
Yeah, thanks, Steve. I mean, look, the legal and regulatory landscape that covers digitization and will, govern whether we can move to a fully digitized health system is incredibly complicated. And that's not just around data fluidity and data protection, confidentiality of all of this stuff, cybersecurity risks, but it's also about the contractual arrangements between commissioners, providers, developers, all of these things. And I don't have the experience in my single sort of clinical risk kind of knowledge. I have to bring in colleagues from across the spectrum of my firm to advise on this, on the commercial aspects in terms of the data protection laws. But it is clear to me that it is an area that needs to be simplified. We've had in the UK the white paper recently on innovation and integration. I think there's recognition there that things need to be changed on that front. I think there are moves to improve this situation. I think some of the regulators, for example, have done sandboxing, pilots where they will provide a safe space for developers to go in to test whether their solutions are going to be regulatory compliant, whether they are going to meet minimum standards. But it's undoubtedly an area where there's a lot to do. Absolutely. I don't think it's all lawyers' fault. I think one of the things that many people have touched on here is that developers are often coming up with these products in splendid isolation, in silos. They are not having dialogues with the commissioners, with those who are going to be responsible for deploying the tech on the ground. And sometimes the market research isn't there, so that they don't know there's a competitor with a very similar product just down the road. So I think all of these things have to be addressed, but it's a huge conversation, and the regulatory and legal landscape that covers this is vast.
Thanks, Dan. That's a really interesting perspective. I think it's probably one that we need to push in next general direction in terms of that question of, is there a way for an organisation like NHS Digital to provide a role in ensuring that we don't develop some of these things in silos. But before I do come to you with that question, Nick, and I will in a moment, I want to go to Abby because he's been waiting patiently. Abby, from your perspective, I mean, particularly, as I say, Mark McDonald, I know you have an enormous amount of experience working in the developing world with lower income countries. What's the state of play as far as some of those countries and jurisdictions are concerned in terms of their digital development? How important actually is it that we look at digital healthcare in these countries simply because it's a way of actually providing healthcare in places where there is none at the moment?
Spot on, Steve. I mean, as MODS, the digital health team here at MODS, we work both in developed economies and the developing countries, and the problems we're trying to address and the things we're trying to help clients in these two different economies are completely different. In the developed world, it's around healthcare facilities, hospitals. What is the role of hospitals? Do we even need hospitals? Which is probably a completely different topic. But going back to your question about low and middle income countries, and Niti touched on this before, they haven't had years of trying to implement EPRs and EMRs and trying to get that right and trying to digitize papers, etc. So they've almost had to sort of leapfrog and to a mobile first world. So they haven't had the baggage, and in which ways, some ways it's been great. So they've gone to a mobile first world, and that's around two things. One, both around the health and well-being and prevention element, but also the healthcare. So, and you made a valid point. In some of these countries, you actually can't sort of turn up at a GP or A&E at a drop, get in a car and sort of get into a GP or a A&E. So it's about how do we use the technology they've got and provide them the right information so that they can focus on prevention and well-being, so that they don't actually enter the healthcare system or only enter the system when they absolutely must have to. So I think the focus is around that, and in some ways, what we're trying to see, what we're seeing at the moment in terms of definitely the solutions and the approaches they're adopting are in some ways leapfrog what we're trying to, what we're doing in the developed economies and the problems we're trying to solve there.
It's an interesting one, I think, in some respects, because in one respect, I guess what you've got is you've almost got a greenfield situation. I mean, Nick's challenge in the UK, for example, is that you're building on top of a system that's been in place for a long, long time and trying to adapt digital technology within an existing system, which must be incredibly difficult. Whereas with lower income countries, with developing countries, you've got a situation where they don't necessarily have the challenges of building on a particular infrastructure in place. But Nick, let's come back to that point that Dan made. How do we, or how do you as an organisation help to encourage a situation where we're not developing in silos, where we're not developing multiple solutions to the same problem, while at the same time, obviously, not discouraging market competition?
Yeah, I mean, it's a real challenge. I mean, it all goes back to a few people have mentioned about standards. How do you have a consistent set of standards, but then how do you incentivize, enforce whatever the right terms are? I mean, I think the sort of at the start I talked about what's your starting point in the system that you work within, and whilst we do have some maybe more long-standing or mature building blocks, there can also be barriers to potentially jump in a generation of maturity that maybe some of the developing sort of countries have an opportunity to do. I mean, how do you sort of enforce that? I mean, bluntly, one way you can do it is through contracting. So I mentioned the difference between general practice and hospitals. We have a mechanism within England where we hold and fund the provision of clinical systems in general practice centrally, and that allows us to have more of a market management role and to effectively drive the adoption of priorities and standards. For political reasons and previous sort of attempts to digitise. We're in a different place in the secondary care world. But there's also, I think there's a real balance between, I also talked about where it's right to do things, in our case, by the state, and where it's right for the markets to innovate. And there's a real tension within that as well. So again, we've talked about the NHS app. I think, there's something like 12 million registered users in England that provides you access to your basic medical information from your general practice records, and actually some fairly basic transactions around repeat prescriptions and appointments. And that was a political decision that we should have, a central utility, which, I think many people would argue, in a system where you have got care free at the point of care, it is right that you should be able to have those basic utilities and access them through digital channels. But at the same time, that also rubbed against the market, and players in the market, felt a real tension about, should the state and the centre support and make the market, or should they, be operators within the market? And I think, when there's a real sort of tension in that, particularly in the system that we work in England, where it, it is, a single payer and generally sort of state funded free at the point of care. So for me, it goes back to that standards question, and about the balance of doing enough, once and centrally, to provide, a degree of uniform access through digital channels, but not doing too much that it stifles innovation and stifles the market to work. And I think sometimes we get it right, sometimes we probably don't get it quite right, but it's, there's a real tension within there.
Yeah, it's fascinating actually when you think about it in the way that you framed that very well. I thought the tightrope that you almost have to walk in the UK because of the nature of the NHS and the nature of the fact that, speaking to Anushka pulling me up earlier on my faux pas about there being one payer in the UK. Okay, there isn't one payer in the UK, but there's one dominant force in the NHS. And that makes it very, very different from the other health economies that we're talking about. And then you have this tension, which is really fascinating that you brought up here, between a digital economy, which is an economy, it's a capitalist market-led economy within a dominant payer, NHS free at the point of delivery, government funded activity. That must make it really, really challenging. And we feel your pain, Nick, I think, from that point of view. I think there is another question that I want to throw at Russell actually on this, which is when we're talking about a multiplicity of different technologies and a multiplicity of different providers into a system, what does that do in terms of your area, or one of your areas of expertise is clearly the security element? What challenges does that add? I mean, when you've got lots and lots of different providers, lots and lots of different sources of data, and lots of different apps and technologies, how the hell do we protect that from attack, from abuse of data, all of those interesting things? Russell?
Yeah, that's a really important question, because I think what CCIOs will recognize is that the more interfaces they have, the more apps they are integrating with their clinical data set, the wider their sort of attack surface becomes. And there are 560 weekly cyber attacks on healthcare organizations at the moment. So it's a major problem, and it shouldn't be downplayed. And I think that there's a real balance to be had. Like Nick speaks about whether something should be centrally controlled, or you should just let it go out to market and have multiple vendors trying to compete for it. But in the commercial space, people are going to be trying to get the next shiny balloon, right? And they might not necessarily give enough focus on the security aspects. And with that, you've got to recognize that your security is only going to be as strong as your weakest link. And if you're connecting up with or interfacing with applications that aren't as secure, then you're putting your organization at risk, and you're not doing your due diligence on protecting that patient data. So I think it's a real balance. I also think that there's a real problem. We've spoken about data fluidity and the need for common vocabulary across the different applications. And that's really important. You can't have a situation where, and we spoke about not having good sleep and not eating well, being on different apps, and you can't have a situation where It's like akin to walking into a room with Alexa, Cortana, Go, Siri, all those things operating at the same time and asking a question. You're just going to be flooded with this mishmash of information. It's not going to make any sense. You need to be common standards, data fluidity within a secure framework.
No, absolutely. I think that absolutely makes sense. I want to kind of move on a little bit to sort of the questions around whether we have the technology, whether we have the right bits and pieces. And Nitty, I want to come to you next, because obviously you see, and then I'll come to Anushka with the same question. You see an awful lot of technologies, an awful lot of startups, and an awful lot of providers. I know both of you do in your roles. Are there, from your point of view, are there gaps? Are there things that we can't do yet that we should be able to do?
Gaps in terms of services, or gaps in terms of just digitization in general, Steve?
I think both. I think both, Nettie, either or both.
Okay, so I think, you know, lots of people touched on what's, I think Simon, I think you touched on it, on what the bad press that the UK NHS GPs have been facing. Lots of my colleagues, I still see patients out of hours, by the way, guys. I'm still a UK practicing.
Where do you find the time?
I don't know. It's just like, I just can't find the will to let that go yet, but I think it's coming close. We've received a lot of bad press recently. And I think the bad press is in that interface between the click and the brick. So that is what we're finding. And across the world, there are new innovative click and brick models emerging. It's a term I coined during the pandemic, because that's what I was seeing. The brick models were changing, the providers were shifting, but that interface between the two of how you seamlessly make that transition between having a great experience online or being able to access online, and then when you need to, where do you go with that? You know, will the brick meet the click? Doesn't often happen in the UK NHS. My husband's a practicing doctor here as well. There's many a slip between a cup and a lip, and you find that for all the lovely stuff that you've done on the clicks, suddenly you want to get somebody in for an investigation or the such like, or results need to be given to the customer, to the patient. And do we have the platforms that allow you to view your record in that kind of way? I think Simon will have a lot to say on that. He and I have had many a lovely conversation about this. So that health ecosystem between the two doesn't seem to be fitting in, especially in mature healthcare systems. It seems to be still a problem.
Many a slip between click and brick.
Click and brick. So the click and brick as well. And then the brick models, lots of people touched on these brick models. And there are in the traditional hospitals where you do, when you're very sick, chronic comorbid, have to go. In places like India, I think Abhi touched on it, we still need lots of hospital beds. You know, whatever they are, we still need tons of hospital beds in these developing economies. But then do they need to be of the nature they are? Can the outpatient services, can we leapfrog the outpatient services? Can we have hybrid models that are smarter? So there's an organization I've been working with. I'm following them for the last 10 years. They're called Seva Mob. I don't know, Abhi, whether you know them. And they're a very interesting bunch. Their brick model is pop-up clinics. Their doctors are not doctors. They're healthcare workers that have been trained to work to protocol, 20 protocols I help them write. And then, if you do need to see a doctor, they work mostly in Uttar Pradesh, Orissa, places like that, where there are no doctors. So this person in a suitcase wanders along on his motorcycle. He is the brick model for outpatient services. They were able to take vaccines very quickly, and they were able to do COVID testing very quickly. They have a pop-up tent. They have a PPE wrapped up around them. The actual brick is a pop-up tent. They stick their finger out from there and they do their COVID test, and off they go, they give their vaccine. And they carry this thing around with them. If they get stuck, they ring the doctor back in Lucknow and they say to him, well, I'm stuck here. What do I need to do next? They carry 20 generic medicines with them, a very different type of a brick model. So the second thing is the type of brick model that is going to interface with this is going to look very, very different. And I think someone touched on, I think Anushka, it was you, on doctors and the culture change required with physicians. I call it the digital dip. I think, Steve, you and I wrote about it 2 or 3 years ago in the World Health Journal about that digital dip you get. when people are trying to digitize services. And that is very true and very real, and people get sick of it. I nearly got sacked by my senior partner when I first started to put in digitized records. This was 100 moons ago, Nick. I'm a very old lady. And my senior partner said, "Who are you? You're mad. I just want to get rid of you," because he just didn't want to be able to sitting in a consulting room and entering on the computer. Now, for some doctors, that's bloody hard, right? You're trying to listen to the patient and you're trying to do that. So that digital dip that you get and that culture shift to make that digital service happen requires a little thinking about. In Bangladesh, when we started to do this with Tonic, you've heard my story before, 17 million consumers using this service now. At the back end, Telenor, Grameen, and insurance coming together into one. And what we found was that if you've got 5 minutes to talk to a doctor online, sometimes their credit runs out. You're in the middle of a consultation, somebody's credit has run out. That's the reality of life in these countries. We wanted to capture the data. We wanted to make sure it had to be a different kind of data capture. You can't be sitting there typing, because that your consultation will never be finished. Now, we can have the pros and cons of, in 5 minutes, you can't see the patient properly. That's what you've got. So when you've got that, you've got to work with that. So drop-down menus, just clicking on the drop-down voice recognition systems that allow you to capture some of this data, code it properly, are some of the things that we're seeing develop, which are gaps in mature markets, which we're seeing somebody else find solutions for. And finally, on the regulator side, so Dan will talk about this. I'm sure he's talked a little bit more about this. It's about saying to people, it's okay to innovate with some of this. It's some of these models on integration. You've got to have open APIs. You've got to trust it. When I started doing this, and 100 years ago, it seems, both EMIS and System 1 said to me, I'm not integrating with anyone else. Thankfully, Nick, it's no longer the case. And you make them open their APIs and integrate with each other. But at that point, they were like, go away, Niti Paul. We don't want to know you. So it's okay to innovate with a bit of stuff. It's okay to try stuff. And for the regulator to take a look at this and say, what is okay innovation, what is okay to take a risk on, and what's not okay. You can't be sitting on this for about 10 years saying, I'll think about it because I'm a little bit too worried about what the risks are. So just identifying, are there real risks on imagined ones, or are we going to really start looking at a consumer slightly different? So those are the gaps that I see. I'm all over the place, guys, but those are the things that I've seen emerging from mature to immature, and just picking up some of the stuff that you guys have been speaking about.
No, really, really interesting. I think, Anushka, to come to you next, where my question to you is this: is the gap in our sort of fantasy digital health system, is the gap, and I think this speaks to part of what Niti was talking about here, is there a gap in the market for something which integrates everything? Are we missing is the missing piece a piece of technology? Stop laughing, Simon, I can see you. Is the missing piece a piece of technology that actually directs you around the system? We don't have yet anything that properly triages where to send you in a healthcare system. Is that even possible?
What a great question, Stephen. I'm glad, Simon, you were laughing, because I was trying really hard to not when Steve asked the question. And before I answer your question, Steve, I just want to touch on some of the points that Niti made, because I think it alludes then to the answer to your question. So if I'm not mistaken, Niti was alluding to what I call for digital, because I hate hybrid, and that blend of physical and digital, and giving consumers the choice. Now, in sectors like financial services and fintech, and I hate going back to that, but it's a sector I know very well, consumers are still keen to have some interactions in the physical space, but more so and more in the digital space. We still don't know, in the environment we exist in now, how many of our consumers in the digital space want to flip back to physical when physical becomes more attractive, appealing, and less of an infective environment. And so I think creating consumer choice within our pathways, within our systems, or physical and digital, and being able to blend between the two and have the data fluidity between the two, and the non-duplicative effort, which I think Niti was alluding to, is very key. Before we even talk about that, and Niti's click and brick story, I think, really runs this point home. Do we actually think our healthcare environments right now are the right ones? There was a test during COVID around remote patient monitoring. There was a test around virtual wards. There was a test around healthcare at home. I know, having worked in South Korea and the ecosystem out there, some of their biggest electronic players are building devices across your home. So your smart home becomes your healthcare home, your hospital home. do we actually know whether we think, hospitals, clinics, GP clinics, and, the infrastructure that we have in place, and let's talk about not the technology infrastructure, but the physical infrastructure, is actually appropriate and right for the populations right now? I think that's the bigger question that no one has actually really addressed. Like, do hospitals need to exist? And if they do, in the current state that they do and do exist in. And then to go back to one of, I think, the third point around that, we don't know how to navigate the system because the system is so complex. I don't think any one player can come in and navigate the entire system because of its complexity. But I think there's a role to play for each of the players coming together and plugging into architecture that allows you to navigate the system. And there was a fantastic article in The Economist recently called Down the Rabbit Hole, where they actually defined the architecture required for decentralized finance. Now, healthcare isn't far off needing that decentralization and that model. And if we, as a group of people on this call and wider across the globe, can define similarly what are the 4 aspects of decentralized healthcare that we can achieve, I think that would be a phenomenal outcome for, let's not say 2021 because it's nearly Christmas. Let's aim for that for 2022. And I wanted to finish on my final point, which you Steve, asked me, is other gaps, and you asked Nitty, other gaps that you see from the, the digital healthcare companies on a daily basis, and not dissimilar to Nitty, probably about 50 to 100 a week of digital healthcare companies across the globe, have worked with several of them and helped commercialize and monetize several of them. And my biggest challenge is everyone seems to be fighting for, whether it's the new mental health app or the new telemedicine service, oh, look, we can put you in touch with X GP and give you access to 1,000 more consultations, and that's you on the way. But no one's actually asking the key question on how do you actually reduce the demand for GPs? Because GPs are a finite resource. How do you reduce the demand for psychologists? How do you allow people and empower the population to self-serve? Particularly, and Elliot referred to this in his discussion, that risk stratification model, so that those that are highest need and most complex get the physical touch service, but those on the other end, medium or low risk, don't necessarily need to. And I think we're all thinking, let's make apps and things, in the environment and new clinics and new services to meet the demand without actually questioning how we re-stratify that demand so we deliver care more effectively and achieve better outcomes. And it's a challenge I'm dealing with right now. How do I reduce the demand on our virtual GP service across our members? What do I need to give the members? And it is, Steve, potentially a triaging tool, potentially some smart algorithmic changes and decision making, potentially augmented intelligence, and potentially some technology and some cool apps. But how do they all come together is the piece that we haven't solved for. And if we can leverage decentralized finance and develop that model for decentralized healthcare and what it looks like and test it, I think we're a long way to solving that crisis.
I think that's the key point, and you raised it perfectly. And actually, today I do apologise for throwing a really difficult question at you, but I thought you dealt with it rather well, because the key question here is navigation. It's all very well having lots and lots of whiz-bang technology that can do cool stuff, but how do you navigate your way around this digitally integrated healthcare system? And I think that's a really, really good point. You clearly hit some chords amongst other members of the panel. Abby, I think I saw your hand go up, and Simon. So Abby, to you first, and then to Simon.
Some really interesting points, massive questions. Obviously, it's not there's no silver bullet to it, and we sort of need to tackle different things to address the challenges within the system. 2 things I wanted to add. One, need to touch on what the low and middle income countries are doing, and in terms of not so much a gap, but what they're doing well in terms of going back to the data fluidity question we had earlier in the discussion. I said they don't have, well, they're not spending time trying to do EHRs and EMRs, but they do need some way to capture the health information system within the system. So they are going to more open source tools, which means that data, again, it's easily accessible, easily available to the different parts of the system. And that means everyone, all the different participants within the system have access to it, which means they can actually use the data to actually inform the services they need to do. So I think that's, and we've seen efforts to go towards open source EHR, EMR within developed countries. The adoption is low, but I think that's potentially one option to some, one lever to sort of go down to enable the data fluidity question we raised. And the second one, Anushka raised about what is the role of the hospitals. Historically, they have been the focal point of the healthcare system. As part of my interaction with the healthcare system, I spent significant part of my journey within the four walls, and that's where I had to go. So, and as mods, the other two services we provide around healthcare planning and which is in terms of informs the services that are required to sort of service the needs of the population, but also building facilities. And we're leading on the new hospital program, which is the Prime Minister's commitment to develop 40 hospitals over the next 10 years. We're trying to sort of help them think about, do we actually need those 40 hospitals? Or even if we do need them, do they need to exist? Do they need to be in the shape and size of what we've done for the last 20, 30 years? So, because we've had a significant change in technology in terms of, which means patients actually don't need to come into the hospitals. We can do a lot of things before, outside the walls of the hospitals. Which means we probably need less number of beds. They need to look the same that we had before in terms of being dark and dreary. They can be more focused on health and well-being, and you can sort of look at the wider different participants within the ecosystem and see how we can sort of shift care to that part. So from what we've seen so far, there are a couple of trusts of programs which are forward-looking and sort of thinking along that way, but I think there's still a long way to go. And for that to be realized, I think digital is going to play a key part in that.
Thanks, Abby. Hands going up all over the place here. So I'll go to Simon and then Russell and then Dan. Simon?
Thank you. I'll keep it very brief, but I just want to throw a bit of caution into the conversation. And this pulls on a couple of things that Niti and Anushka mentioned around managing demand and signposting. So we were commissioned a while ago now to do a review of online triage tools. So things that members of the public can go and click on, and they get taken through a sort of question answer algorithm and told, don't worry, phone your GP and see them when they can, or, oh my God, phone a big white taxi, go to hospital. And we were commissioned to a review of these, and what we found was, unsurprisingly, the algorithms driving most of these are incredibly conservative. So what happens is they drive an awful lot of people to higher intensity care than they actually need. An awful lot more people were told, go to A&E, than actually need to. An awful lot more people were told, go and see your GP immediately when they could self-care. And that's partly a safety feature, but it's partly a lack of maturity of these kinds of tools and the risk models behind them. So I think we do need to be cautious of piling headfirst into the digital future when the understanding, the maturity, and the services that digital future requires aren't there yet in the real world.
It's a really, really interesting point, actually, that when we're talking about digital healthcare, we fail to consider, which is the great law of unintended consequence. You know, piling into doing exciting new digital things, what might that mean that we didn't mean it to mean? And it's a really, really good point as regards to the kind of digital triage tool. Russell, you wanted to come in and then to Dan.
Yes, thank you very much. First of all, can I just say that I'm really enjoying this discussion. It's an absolute treat to be connecting up with all of you. And we're speaking really about, we're speaking about the venue of care, right? And which is the correct venue of care. And I think we have to be careful about being absolutist around what the correct venue of care is. It's going to be different for different patients with the same condition. And at the moment, I think the thinking is very much like, oh, this could be done in the community. This can be done at home. This is a self-care sort of environment. But actually, we need more data to be able to make a correct distinction as to whether that patient should be coming in and seeing a physician or going to see a clinician, or can be self-treating at home. And I think that until we have all that information, the algorithms, as Simon said, are going to be too conservative, and we're going to be creating a rod for our own back. The clinical pathways are not going to be standardized. They're going to be personalized. And the same patient will have the same thing happen, but they're going to have different workflows for their clinical care when this all starts to come together.
Thanks, Russell. Dan, over to you.
Thanks. I just wanted to pick up on a couple of points that both Anushka and I think Simon mentioned. I mean, when you're talking about navigating the system, you're not just talking about the tech that's there to enable people to navigate the system, but the end users themselves. And I think one of the issues I just want to pick up on, and I'm pretty passionate about, is digital exclusion. Because even in the UK, you know, one of the most developed and richest countries in the world, there are 11 million people, 20% of our population, who just, you know, don't have the necessary digital skills and equipment to navigate a digital health system. Many of these we know are likely to be older, to come from you know, less educated backgrounds, and to have some of the chronic conditions that really could benefit from some of these digital tools. So I think we've got to recognize that there is a risk that if you rapidly move to a fully integrated digital health system, there's a risk of a two-tier system here, and you've got to find a way to mitigate those risks. It just seems to me that for these groups who really could benefit perhaps the most from digitized solutions, those with chronic health problems, those who really find it difficult to get to hospital appointments, we've got to do something to mitigate that. Otherwise, it just seems to me the risk of health inequalities and, you know, increased isolation even may well be exacerbated by digitization. If I think, you know, back to the experience of my grandmother when I was a child, you know, for her, the sort of weekly trip to the GP or to pick up a repeat prescription, it's not just a medical necessity, it's a social occasion for some people, you know, and whether that's right or wrong, if you take that away, then there are, as you said, unintended consequences. I think as well, you've got to think about the clinicians. You know, on the one hand, you're going to have the tech evangelists who are going to, you know, want to roll this out as fast as possible, but you've also got some of those then who are more conservative. And I think it's about trying to bridge this divide through education, training, and making sure that clinicians really understand not just the potential benefits for improved patient outcomes, but also the actual rather than the perceived limitations of what tech and digital health can do. And I think that brings back to the point of, you know, is it about digital healthcare, or is the priority really digital triage and moving that triaging system to the point of the home rather than the hospital?
Some really, really interesting points, Dan. And the one that I particularly like there is the one about people. At the end of the day, you know, there's no point in developing a digital health system if we don't bring the people with us. Anusha spoke eloquently at the beginning of the conversation about the willingness of the population to embrace digital solutions. But you've spoken equally there about not leaving people behind because they don't have the digital skills or they don't have the access to the infrastructure and equipment in order to do so. Again, a delicate balancing act, I think. Elliot, you wanted to come in.
Yeah, I did. Just to that point about exclusion, I think that you definitely end up trading one set of problems for, you can end up trading one set of problems for another when you digitize a process, or you could amplify problems quite quickly when you scale a digital solution. You need to be really careful. But I don't think we have to turn old systems off in order to turn new systems on. And we certainly shouldn't be doing that, because that will end up with exclusion. But I just on the, you know, to fight the corner for digital, that by implementing solutions where people can self-manage or they can book their own appointments, I think this reduces demand on the system, which frees up capacity for those 11 million people that don't have access. So I don't think it's a reason not to do it. I think it's a reason to do it. And I think we're often looking for, like, why is it not happening? So is it that staff aren't ready? Is it that patients aren't ready? Is it that the interoperability is not there? I think all of these are largely solved problems, if I'm completely honest. And I think I just hope that we just get on and start implementing technologies at a faster pace. I think that's the problem. We asked the question earlier, what's the breakthrough that we're looking for? I don't think we're looking for a breakthrough. I think all the technologies exist. Nothing's perfect. It never will be, and it's constantly evolving. What's not happening is we're not implementing technologies quickly enough. And I think that the risk of implementing technologies versus not is now, the balance is very much in the favor of we now have much more risk because we're not implementing new technologies into the health system.
Thanks for that, Alec. So we've got 10 minutes left, which is a real shame actually, because I could go on all day with this. I think it's been a really, really fascinating and fantastic debate. So what I want to do to finish off is I want to go around my panel, give you all one sentence, please. I know for some of you that might be challenging. It certainly would be for me. What is the one thing that if you ruled the world, what's the one thing that you would shout about to say this is the number one thing that we need to worry about, the number one thing that we need to think about? And I'll go to Nitty first because she likes being put on the spot.
Oh, what would I like to see? I would like us to be much more consumer-centric in our behavior around digitization, because then you get access.
Thanks for that one, Nitty. Anushka.
I always fall in Nitty, which I don't mind, but it's always difficult when Nitty comes up with very powerful.
I know that you can handle it, Anushka. That's right.
I think for me, I'm going to jump on the accessibility wagon, and I think just going on exactly what Elliot says, we have a trade-off to make. If we go completely digital, then we lose that accessibility, inclusivity, dimension, and I think it's really, really critical in the environment we live in now that everything we do takes into account accessibility and inclusivity. So for me, I'm going to say the most important thing is digital accessibility standards, but also having a get out of digital free card for those who don't choose to engage with digital.
Ensuring that there is still access to the right healthcare for people that can't use a computer or a smartphone. Absolutely key. Danny Seedine, do you want to give us your pearl of wisdom?
Sure, I'll try to do it in a sentence or two. I would say that the key, in my opinion, really has to do how do you manage the identification of individuals that are essentially consumers within healthcare, whether it's through clicks or bricks, as others have described it, in either of those settings, in a way that also preserves their privacy when they wish to maintain privacy under certain types of transactions. I think that's the key, because if you can't do that, then all the other data that you're collecting, which is super important, obviously, and has to be very fine-grained, none of that information is going to matter because you can't correlate it together. So I believe that is a key element for digitization going forward.
Thanks, Danny. Abby, what about you? What are your thoughts?
My one thing is left shift of healthcare. So if it can be done in the hospital, or if it has been done in the hospital, perhaps it should be done before the hospital, outside the hospital. Or if it's similarly, if you're focusing on healthcare, then focus on the health, so the prevention and the well-being, which then addresses some of the challenges we've talked about in terms of reducing demand and trying to create the right services for the right people. So left shift.
So but essentially trying to take the healthcare out of infrastructure as much as possible and deliver it in the home or in other environments.
That's one element of it, but also in terms of before, from a patient consumer perspective, instead of having to interact with the healthcare system, let's focus on the prevention and well-being, so they're healthy in the first place.
So the health versus healthcare question. Yeah. Dan Morris, to you.
Yeah, I think there's really two things I would focus on. First is digitization of social care, certainly in the UK, just seems to me lags behind somewhat digitization of pure health. And if we're going to have a truly integrated health system, then it has to encompass social care. The idea of integration and data fluidity between sort of discharges, daily care planning, some of these smaller care home providers don't even have the Wi-Fi that's there to deal with this stuff. So the basics are just not in place. So I think that has to be dealt with. Just the second thing to say is I think there's a real opportunity, and I say this against the backdrop of the COP26 climate change conference going on. I think there's a real opportunity for digital providers, developers, entrepreneurs to emphasize the green credentials of digitized solutions and how they can benefit hospitals and healthcare systems going forward, because I think that's going to be an increasing area that funders and investors are looking at as we move forward.
Thanks for that, Dan. There is always one panelist who, when you ask for a single point, will cheat and make two. Thank you for that. Russell, over to you. What's your one thing?
Well, you asked for one. I'm going to give you 4, Steve. So my request would be that any change, any interaction, any innovation, any application in digital health is looked through the eyes of the quadruple aim from the IHI in terms of improved health outcomes, lower costs, better patient experience, and improved clinical experience. And I think if we looked through that lens before we made any change, we would be in a much better place today.
Fantastic point, Russell. Thank you very much for that. Simon.
Well, I'm not going to go with 4. I'm going to go with 3. A philosophical point, which is think about why. Why are we digitizing this? What's the purpose? What's the benefit we're aiming to achieve, and who for, before you do anything? A second one is technical, standards. Standards. And then a third one is a plea. There is an immense amount we can do now in order to use data and solutions that are already available and can be brought together to improve wellness, to improve services, and to mitigate risk. Can we please just get on with it?
Thank you, Simon. Elliot, over to you.
Okay, so 2 then. So the macro one.
It's Dan Morris's fault for starting this.
Exactly. So the 2 I would go for. So incentivized partnerships. I think the biggest problem in healthcare aren't going to be solved by any individual entity. I think it's going to be companies coming together, entities coming together to work together. So we need incentives to do that. And so that's probably one for Nick. From our world, I think that ultimately that there's still going to be healthcare professionals delivering care, human beings caring for vulnerable human beings. Those people need better tools. I would love to see better tools in the hands of healthcare professionals to do their jobs better.
Fantastic, thanks, Elliot. And Nick, let's finish where we began. What's your pearl of wisdom then? What's the one thing, the one message that you would like to give to our audience today?
So I think, wouldn't it be great if we had a magic wand to not enforce, but to, the market and everyone in it internationally did want to play, with some consistent standards. So, to Simon's point, sort of standards is just critical. The other sort of point, which Elliot touched on towards the end, is just around risk. And I think there's different ways you look at it. I think we didn't really touch on skills. And I think probably, the skills of us working in healthcare systems to have the confidence to take risks, to try things. But conversely, Simon also mentioned I think probably maybe a disproportionate sort of view around the risk around data sharing by smaller sort of pressure groups quite often change the dynamic and maybe get an unhealthy view on data privacy that probably adds to that sort of risk aversion. So standards, and then a proportionate focus on risk.
Fantastic, Nick. Thanks very much, and thanks very much to everybody. I think the measure of one of these sessions is if you get to the end of it and you think, my God, I'd like to go on for another hour because this is really interesting. You've probably done quite well. And I think from that point of view, certainly my feeling is that was a really lively, interesting, enjoyable debate. My takeaway from it, I think that the answer is that we have most, if not all, of the technologies that we need to create this digitally integrated healthcare system. But the problem is that we don't quite know what it is or what it looks like. There's a really interesting piece of work that maybe I'd like to get involved in over the next few months about how you map that. And it might be interesting to bring some of these, my panelists today and some of you out there in the audience together to discuss how you map that digitally integrated system. Where do the technologies fit into that birth to death timeline? And actually, how do you navigate, to take Anushka's point, around that digitally integrated healthcare system? So maybe that's where we go next with this. But thank you very much. It's been a wonderful session. I see that there have been a large number of people watching us, so thank you all for sticking with it. It only remains to thank Nick Fox, to thank Nitty Paul, Russell Main, Elliot from Infinity, Dan Morris, Abby Shecker, Daniel Sidon, Anushka Pachava and Simon Swift for an absolutely brilliant panel. Thoroughly enjoyed it. We'll be back next week with our session on the need for a global clinical standard. But for now, from the Healthcare World Festival, goodbye and have a great day. Thank you. Bye-bye.